Ladies and gentlemen, please welcome my good friend, Jon Tirmandi.
So, my mother, she chose a beautiful place to tell me that she had cancer. It was an indoor garden tucked away in the middle of downtown Calgary, a place called Devonian Gardens, plants, running water, quiet, koi pond. The kind of place where you go to take a break. Around us, business people of all ages on their lunch breaks. I was 19. And I was interning at the same building that she worked in. And one day she asked me to lunch and we sat down. And she told me the way that she told me everything that was difficult, directly, calmly, without drama. I started to cry. I couldn't keep my composure. And the thing that I remember the most all these years later is that she was the one that was reassuring me. My mother, she was holding her own diagnosis and mine at the same time. And I just remember feeling so sad for her, so uncertain about the future. And she would be that way the whole way through, stoic, strong. And she fought harder than anyone I've ever known. And from that lunch onwards, she didn't fight alone. She had us, of course, her family, but she had a great oncologist. I remember he was a lovely man. Her cancer, breast cancer, it was really aggressive. Really aggressive. Stage 3. And my parents, they wanted to throw everything at it. So they flew her to MD Anderson in Houston, the best cancer clinic in the world, for a second opinion. And the recommendation came back identical to her Canadian doctors. Do exactly what they're doing. So she stayed. Chemo, then radiation, then remission, and we celebrated. And 2 years later, it came back, and 30 months after that, she was gone. And through every chapter, we had the same doctor, we had the same hospital, the same nurses that knew her name, and she was held. Through all of it. And my parents never paid a medical bill, nothing, not a significant one anyway. And I remember my dad saying, had we done this treatment at MD Anderson, we would have had to sell everything. And I know that our experience isn't unique. It's the experience of so many in this country who, in their hardest moments, have a health system to turn to, and that health system is precious. The Canadian health system is precious. It heals. And the people who serve in it, at least from my experience, try their hardest not to leave anybody behind, not in the worst moments of their lives. And the reason why I'm up here talking about how we might rebuild healthcare in Canada from the ground up is because I think that this precious health system is under strain. And so let's look at the country really honestly. We're living longer, but not better. Healthy life expectancy has dropped nearly 2 years since 2019. And nearly a fifth of a Canadian's life is now lived in poor health. We're overweight, we're diabetic, we're depressed. 3 in 10 adults are obese. Diabetes is up nearly half in a decade. Youth mood disorders have nearly doubled in 7 years. Almost 10 million of us live with chronic disease, up 11% in the last decade. We're spending more than ever, almost $400 billion a year this year, nearly $10,000 per Canadian, almost 13% of our economy, $2,000 more than Italy or Spain, and yet 7 million Canadians still don't have access to a family doctor. And if you don't have access to a family doctor, you don't have reliable care. Let's talk about our doctors. Our doctors are burnt out, our nurses are exhausted, and we cannot train or retain enough of them to keep up with the demand. But we're doing more surgeries than we've ever done, and we still rank dead last among 10 high-income countries on timely access to care. 47% of Canadians wait 2 months or more to see a specialist. 59% of us wait 2 months or more for elective surgery, and only 1 in 4 can see a doctor when they need to. So clearly, the system is struggling to keep up with our needs, and it's on an unsustainable path. So why is it like this? And there's no shortage of explanations. Maybe it's the funding model. Maybe it's the federal and provincial split. Maybe it's our aging population or workforce shortages. And everyone has a theory. And I think that they're all partially right, but I think that there's also a deeper answer, and it goes back 60 years. Many of us know the story of Tommy Douglas, the father of Medicare. But what most of us don't know is this: even he didn't think Medicare was finished. Medicare was built across this country in the 60s, and looking back at what he built, Tommy Douglas warned us it was always to come in two phases. Phase one, build universal access, remove the financial barrier between people and care. And phase two, in his words, would be to reorganize and revamp the delivery system. Phase one was built, it's the system that we have today. And phase two was never really started. And since then, we've defaulted, decision by decision, compromise by compromise, never really asking what our system could become, maybe until tonight. Thanks for the opportunity, Nick. So if we're going to rebuild from the ground up, we wouldn't start from zero. We'd start from where Tommy Douglas left off. We'd finish what he started. And phase two starts with one thing today's system doesn't have: people. Our system today is designed around the institution, the building, the funding model, the org chart. And we need to flip that. Phase two has to be designed around them: patients, caregivers, clinicians, administrators. And Tommy Douglas saw this too. And tonight I want to walk you through 5 foundational enablers, 5 things that could put us on the path to rebuild healthcare around people it's meant to serve. And I've drawn these from health systems around the world and a few examples from right here at home. And the best part about these 5 enablers is that they already exist. They're just not here yet. First, from Estonia, data sovereignty. Ownership of your health information from institution to you. You should own your data. You should control who sees it. It should follow you across every clinician you see. For patients, it would mean agency over their own care. For caregivers, it would mean access to help the people that they love. For clinicians, it would mean the whole picture, not just a slice. For administrators, cleaner data, fewer errors. Even if you don't have a family doctor, the next clinician that would see you already knows you. Estonia built this 20 years ago. Your record carries your story, and you carry your record. Second, from the Netherlands, interoperability. The system carries your story so you don't have to. Right now, if I walk into Trillium Health in Mississauga, I'm a total blank slate. It's crazy to me that my instance of Claude, Anthropic, knows more about my personal health than any clinician I would ever see. It's completely unacceptable. The Dutch built this, again, 20 years ago. When a patient walks into any clinic, the people treating them know their context, no retelling the story, no duplicated tests, less burnout, real savings. Imagine the savings in dollars and in frustration. And there's probably going to be some talk about AI in healthcare. Without data sovereignty and without interoperability, forget about it. There's no AI in healthcare in Canada. Third, personalized medicine. From Australia and the UK, personalized medicine, care built around your biology, not the textbook patient. We are not average. Targeted treatments mean better outcomes and staying healthier longer. Australia is building this for kids. The UK is building this for adults. We have the chance to build this for everyone. I bet you a bunch of people in this room know your risk profiles for disease because you paid for a genetic consult. I did. So why shouldn't every Canadian have that same service? Who wants it? Fourth, from Finland, population level prevention. The system protects health before disease ever arrives. The best way to reduce strain on our system is to keep people healthy first. Finland did this starting in the 70s, salt reduction, smoking cessation, dietary educations, and they committed. And they stayed committed for 50 years. I think this is the main difference between us and them. They stayed committed for 50 years. And 40 years later, cardiovascular mortality in middle-aged men was down 80%. Fifth, I chose an example from right here at home. Care where it works best. Care that follows you, you don't follow the building. UHN was just ranked in March this year the 2nd best hospital system in the world. We do hospitals great, and that's amazing if you live in downtown Toronto. But in a country this big, most care doesn't need to happen and can't happen at UHN or in a hospital system. Telemedicine, surgical clinics, community-based imaging, they scale, they cost less, they meet people where they are. And we're already doing this in Canada. There's a group called Scotia Surgery in Nova Scotia. It's an amazing case study. They do orthopedic surgery. The Ontario Telemedicine Network, UHN's home hospital programs. The proof is here. We just haven't scaled it. Now, you might be saying this sounds expensive, but consider that $1 invested in prevention returns 4, sometimes 46. Estonia saves 2% of its GDP every year through digital health. And surgical clinics like Nova Scotia Surgery save $2,700 per orthopedic surgery procedure compared to doing that same procedure in a hospital, and it frees up a bed. Every year we don't do this, we leave billions on the table. So phase 2 will pay off. But it's not just about money. In Australia, more than 9 in 10 children with high-risk cancers now have their molecular driver of their disease identified. That opens up new treatment pathways for them. Children who just a few years ago had run out of options. Quebec, who's probably modeling it based on Finland, has modeled $38 billion in productive life by eliminating cardiovascular disease. Life Canadians get to live, work, raise families, show up for the people around them. So phase 2 bends the cost curve, but it also bends the human curve. So how do we get started? Let me tell you what we're doing now is not enough. Governments across this country are overhauling healthcare. Alberta, Quebec, Ontario, Saskatchewan. We have real reforms, primary care, integrated teams, expanded scope, but they optimize the system that we have today. They don't redesign the architecture. Care still flows downstream of illness. The data still doesn't follow you. The system is still organized around institutions, not people. In my opinion, this is moving the deck chairs. So where do we really start? 2 moves. First, we need a mandate from the top. This is public health. So we need the political will. We need a visionary leader. We need a push from the electorate. You know, I think that we should be embarrassed by the state of our healthcare. We really should. We should be angry. We should be demanding change. We're paying for better and we're not getting it. And until we do that, mandate won't come. But one day it will come. And when it does, we redesign healthcare service by service, not from Ottawa, not from the provincial capitals, but in the field, with patients, like Jennifer said, with patients, the caregivers, the clinicians, the administrators, the people who actually carry the system. This is how transformational innovation is done when it's done well. It's done from the ground up, not from the top down. You know, from personal experience, I know how difficult it is to know when something is wrong, to see a physician and not get answers, to go from specialist to specialist, to run the same test twice, 3 times because nothing in the system talks to each other. To watch doctors dismiss the AI analysis that I prepared for the appointment because they don't have the time or trust to engage with it. And I don't think that I'm the only person in this room that's like that. And look, I have the means to pay my way around this, and when I get stuck, I do. But most Canadians don't, and I just don't think it's right that I get better care just because I can. 1 in 4 Canadians say that their health worsens while they wait, and that's not right. So, it's time to choose. Are we going to design the future of Canadian healthcare? Or are we going to default to this one? We already know that the system that we have doesn't work, and we need to do better. We need a system that shows up for every Canadian throughout their lives, and in their worst moments, one that holds them with dignity. You know, my mother, she had 30 months. 30 months between her reoccurrence and her last day, on a system that in that time held her. If she were diagnosed today, her drugs, the treatments would be so much better, like immeasurably better. But the system around her would be way weaker. And it really begs the question, would we still get the 30 months? Our medicines have improved, our system is collapsing, and we can't accept that. And we have a choice tonight in every conversation we have after we leave this room. The Canadian healthcare system, will it be designed or will it be defaulted? Thank you.